So thank you everyone for making time to be here today. And I don't know if y'all know, but Prideville is the fastest growing city in the state of Oregon right now. And so I just encourage you all to take a spin through town. There's a lot of.
So when you go home, make sure to tell people how horrible it is.
Yes, tell them all how horrible it is.
Nice strikes on
A lot of investment, a lot of really embracing of the character of Prideville and of Cook County. So if you have an opportunity, please drive around and take a peek. It's really pretty impressive. So great to have you here, Judge Comfort. Nice to see you. So we will start with a welcome, public comment, and announcements. So let's start with introductions. And Brad, do you want to kick us off? We'll go around the table. Go to Miguel and Kayla and then kind of just wander through. Oh, and okay. Yeah, we have a few people on Zoom. Wonderful. Okay.
Yeah, Brad Porterfield, consumer representative and the chair of the Community Advisory Council.
Tammy Beatty, chair of the Health Council, your tour guide today.
Carmen Madrid, executive director. Linda Johnson, community rep and vice chair.
Gary Allen, vice president, clinical services, Advantage Dental.
Seth Crawford, Cook County Judge.
Patty Dare, Deschutes County Commissioner, shortest person in the room, and I want to acknowledge Dr. Mike Baker for his fentanyl billboard in Matters. It is amazing, from 18 to 45, leading killer, and it was something that your team designed, and it's outstanding. So thank you, Dr. Baker.
All the love for Jefferson County today.
And the cool truck. Yeah, my name's Rick Levin. I'm the CEO of Best Care Treatment Services and your behavioral health board member.
Awesome.
Miguel Ángel Herrada, project manager of the Showcase.
Michaela Arsenault, representative. Chief Rehearse.
Dustin Zimmerman, Oregon Health Authority.
Neil Smith, Central Oregon Health Council.
Jeremy Vandehay, Oregon Market President, Pacific Source Supplies.
Yay, nice to see you again.
Mike Shirtcliff, representing Method Dental Group.
Janet.
James Garcia, Health. Tyler Kaiser, public health director.
A few months.
Leslie Neubauer, senior director.
Trish Wilder, CEO director, Central Oregon.
Great.
Gwen Jones, Chief Rehearse, project manager. Health Council.
Awesome.
Katie Plum, public health director.
So we're putting a plug for a truck for you with the wrap on it. Mobile. This is better. Dr. Ross, nice to see you.
Good to see you. I'm Rob Ross. I'm the director of education and research.
Awesome. Yes.
Aaron Lawson, Central Oregon.
Wonderful.
Net theory, Central Oregon.
Great.
Mike Baker, Jefferson County.
Awesome. Yay. Okay, joining us virtually, we have Kristen.
Hi, Kristen Tobias, she, her pronouns, and I'm the Senior Community Health Coordinator for the Central Oregon CCO.
Excellent. Megan.
Hi, Megan Hayes, she, her, and CEO at Mosaic Community Health.
Awesome. Paul Andrews.
Hi there, Paul Andrews, Superintendent, High Desert ESD, he, him, his.
And I can't see the last person. I can kind of see your face.
Could be Lori Hill. Could be Lori Hill with Central
okay.
Oregon Pediatric Associates. Could be.
Okay, wonderful. And who else do we have joining us that maybe I can? Oh, Commissioner Similink, go right ahead.
Hi, everybody. Commissioner Similink, Jefferson County.
Excellent.
And hi, Lindsay Atagi, she, her, Pacific Source Community Quality Coordinator.
Wonderful, thank you. Anyone that I missed? Okay, I think we're ready to kick off. Do we have public comment? Sorry? No. Okay. Any comment? No comment? Yes, go right ahead, please.
Celebrate.
Yes, we want to celebrate.
Finish the Healthy Oregon program.
Yes, we do. Yes. go
Cover
ahead.
every Oregon, I just think that's a fantastic thing. Thank you, Oregon. Thank you. for the good ones.
Yes, that is a good thing. Yes, awesome. And what, I mean, so that impacts, that our families and, you know, that's a big deal. So do you want to say more about it? Like what would,
I mean, there's been a segment of our community, specifically in documented immigrants, unauthorized immigrants who have been excluded from healthcare. Program tends to be low-income families that are needing that care. People who generally don't access care other than through cats here, but volunteers in medicine. And was like, so just opening the doors of opportunity to every single one of them is a big one.
that is a big deal. Nice. And thank you for your work on that, on behalf of the underrepresented and those that feel that folks too. So thank you. And yes.
I just
Yeah.
wanted to, I just wanted to acknowledge how great it is to have our two county commissioners from Cook and Jefferson County in the room and in the meeting. So important to build relationship for whatever comes along the way. And if I know Patty's been a regular attender, but we've missed the two of you. And so thank you for coming.
Ah, look at that.
Thank you so much.
Commissioner love. All right. Wonderful. Other comments or anything that anyone else would like to bring forward? Okay, so let's go with the consent agenda. Do we have any changes to the consent agenda? If not, I would welcome a motion.
So,
Ooh,
second.
You can battle it out. All right.
Okay.
Any further discussion? All those in favor?
I
Oh,
just
sorry,
have a
please.
question
Yes.
on the consent agenda. That does not, oh, yeah, it does include the financials. I'm assuming that that means that the finance committee has reviewed those and those are ready to, they're ready for acceptance.
Yes, yes, it usually goes through the finance committee before it comes to the board. Excellent, yes. Any other discussion? All those in favor?
Aye.
Anyone? opposed? Oh, thank you. Okay, so let's move on to Crook County on the move. Come on down, yeah. Hi, Kat, good to see you.
Okay. So, you was, you done that?
Yes.
So the Cook County on the Move is a program of the Cook County Foundation. They're celebrating their 25th year this year. And we're a network of community members and organizations who are passionate about creating a healthy community. And we do this through 3 focus areas of keep moving, be nourished, and stay refreshed. We should have a slide
Oh.
when you moved it. I think we just need one down.
Good sleep over.
Yes, yes. Oh, great.
There you go. Okay. So Carol and Christy are going to present on one of our focus areas, the Be Nourished, and their current work, and that's pretty exciting. So go ahead, guys.
So first thing we're going to talk about is our 2023 community garden party. This was our 3rd event. We did have the 2-year hiatus. Everybody knows why. But our original goal in 2018 was that we really wanted to introduce people to gardening and give them all the resources they would need to be successful in gardening, and also to support our community gardens. While we continue to offer those that information about composting, planting, harvesting, and growing our foods, in 2023 we really kind of expanded out to be a celebration of healthy outdoor activities also. So next slide, please. So this year we had 95 families showed up, so it was about 250 people. And those are just the people who actually registered. We had other people who came through who did not register. We had 20 community partner agencies that showed up. We had both the agencies, organizations, and a few businesses, and each one of those provided a learning station and also a fun activity. And so we used bingo cards to get people to go around to every single station, and we gave prizes for that. And we want to really thank COHC for joining us. Miguel and Carmen came, and they provided an opportunity to do the RHA survey and also get a custom henna tattoo.
Wow. So next slide, please. So Share the Bounty is a promotional campaign during the harvest season to tell folks where and when they can donate their excess garden production. So we use print advertising, flyers, social media to help spread the word. We also, next slide, please, post some pop-up sharing tables at various events to both share the excess produce and have wonderful conversations about family favorite recipes. The produce is collected, some produce is collected each week at the close of the local farmers market, and that produce is distributed to the food pantries here in Crook County so it doesn't go to waste. Next slide, please. Actually, I'm going to back up one slide. I had one more thing to say. The one thing you will see the bags there, the grocery sack there, that is a fresh harvest kit. We partner with High Desert Food Farm Alliance and Boundless Farmstead to create these fresh harvest recipe kits. It contains everything to make that particular dish. This harvest season, they're being distributed at local food pantries and at the ODHS office parking lot. So now we'll go to the next slide. Last November, the manager at the self-sufficiency desk in Prineville at the ODHS office identified a real gap in access to food. Families who are newly in crisis and are applying for benefits sometimes either need a bridge to get them through just a few days to get them to an open food pantry, or they might need a bridge to get them their SNAP benefit card, or sometimes they just don't qualify for those SNAP benefits, but they still have no resources. So we have been filling since December bags of food to get them through 2 or 3 days until those other resources can kind of fill in. Since December, we have provided 153 bags. That's approximately one every working day that has gone out here in Prineville. The growing need for food assistance here in Crook County and regionally is limiting how much we can rely on St. Vincent food, the food pantry, to help us fill those bags. And so we are currently looking for ways to help fund this really needed program.
I have to add, we just found out yesterday, there's other counties in Oregon that are looking at this program to replicate and help their citizens too. So that was pretty cool. Next slide. Several years ago, there you go, on our Stay Refreshed focus group, we had age-friendly community meeting. We had a doctor from Portland State University come and educate us on how to create a community that's more age-friendly, because probably 25% at least senior citizens. So we had a huge component of seniors and retired people here. Well, we learned we had these amazing parks and great trails, but people with limited mobility couldn't access them because there was no place to sit. So Carol became known as the bench lady, and through community partnerships and funding from several organizations, both national, regional, and local, including Central Oregon Health Council, we now have 60 benches along our trails, in our parks, and in different places and community spaces around Prineville. The really key thing to these benches is we worked with a physical therapist. because they are designed at a certain height, and as you'll see, there is an arm in the middle of them, so when people sit down, they can get back up. They also have a cement pad next to them, so if they have a walker or somebody's in a wheelchair, they can join the person sitting on the bench and feel included. So next slide. These benches came in really handy when we started our pilot project this year called Let's Walk Together. We worked with St. Charles staff to design this program, and it was made to demonstrate how small daily changes can add up to make a big difference in our lives and in our health. This 12-week walking program was designed to encourage people of all mobility levels to move more, experience a variety of healthy lifestyle experiences, and increase community belonging. So the picture here on the right is Jabberwockies, and that group actually ended up splitting into 2 groups because they had people that were slower. We had a 93-year-old with a cane and a gal that actually gauged her progress by how many benches she got to over the period. She would sit at that bench and wait for the rest of the crew to come back and join them on the return walk. So it was amazing to see how the benches actually really helped our participants.
She got up to being able to do a mile at the end.
Yeah, and the first day she could only make it to the next bench. So it was amazing. We ended up with 8 hosted walking groups, walking on different days and at different times. 3 of these walking routes included places where benches were. And we also had, next slide, we had, mamas with strollers. So we had a great group of mamas with new babies, new families. Actually, grandma came to this group with her grandchild also. And then we had a group with St. Charles called Pacemakers. And they had a midday break. And it was really cool because not only did it give the employees a break from their day and refresh them, our community members actually got to meet their caregivers on a personal level. We wanted about a 30-minute walk. They came back and said, can we do 20 minutes? It's like, why not? Because they didn't have time before they had to be back to work. So our rules were kind of meant to be broken because this was our pilot project. And we really worked hard to get St. Charles to find the host department to do this group. After like the second week, I got an email back and said, okay, we're doing 2 days, but we're having so much fun. Can we do all 5? Why not? So they walked all 5 days during the break. So that was really cool. And the next slide. Part of our walking groups was not only the walking groups, but giving these people other experiences, ways that they could keep healthy or learn about healthy lifestyles once our walking groups quit. So this was our Steps Against Melanoma walk. It was in May. We also had our community garden party in May that they could attend. Participants could log minutes, and that's how they entered their minutes to earn prizes. We didn't care about the miles. It was about how long you moved or that you participated more than it was about distance or abilities. And so Steps Against Melanoma was a free benefit walk as we introduced the community to the importance of benefit walks, and that even if you're a walker, you can contribute to the community in that manner. You don't have to run to take part in this. It was an amazing event. We were the smallest community that participated in this first year that we had it across Oregon, and we had the most participants of the new communities in this effort. We educated them on the awareness and the seriousness of melanoma. Most people don't think it's really any big deal. We also showed them how to recognize potential signs and how to protect their skin in the Central Oregon sun so that they could enjoy the outdoors and not be afraid. Next slide. In June, we had some simple hikes out at Sunlight Farms. 2 easy hikes were mapped, a 1 mile and 2 mile option. On the next slide, we were surrounded by some beautiful nature. We also had mindful movement sessions, simple yoga that we did in mid-hike on the 2 mile, and then the whole group did it when we returned back. We were able to learn about the farm, and we also were able to purchase some lavender plants. So we worked in a little shop. You have to do that. We had prize drawings, enjoyed healthy snacks and conversations afterwards. So that was a really fun experience. And the next thing we tried was our first Dish Up Prineville event called Superfood Snacks in a Snap. It was heart healthy foods taught by Amy Chadwick, who is the St. Charles RN. their body. She had a conversational presentation about the food where we could ask questions. She taught us which foods and which spices help nourish different parts of our body. We had just great conversations, and then we got to eat the delicious food. So that was great, and handed out a few more prizes. Other group experiences that we had that people could participate throughout the event were some of our online experience maps. We did an art walk, just kind of ad hoc, just said, we're gonna meet Saturday before farmer's market. We walked to the downtown core and looked at public art, returned to the farmer's market for mindful movement, and then shopped at the market. So this is our group here that showed up too. That was just participants from all 8 walking groups that showed up there. And then next slide. We also, during COVID, with the library, we partnered and did a Be Well video series on YouTube for their winter wellness project. So anybody that watched those videos could log 10 minutes and learn different things. We had things from protecting your skin to Qigong warm-ups. We had create kindness art so that you could create a little tag and show kindness to your neighbor. And Dr. Good here at St. Charles even created a video on her own where you could sing to gauge your exertion level. So if you're around down in Prineville and you're seeing somebody going down the street singing, they're just checking to see if their heart's beating too fast. So again, walkers could earn minutes for participating in all our experiences and utilizing our resources. And the program just showed us how easy it was to feel better and be more energized by taking that first step, literally taking the first step. Next slide. So the results, where we had 106 registered participants, we hoped for 30. We planned for 3 groups walking 2 days a week for about 30 minutes, and we had 8, in addition to Prineville Oregon Running Club, who would accept walkers. We walked every day of the week but Saturday. There was options to do that. We demonstrated that small steps do add up over time. Not all of the participants logged their time, but of the 53 who did, we walked over 36,000 minutes. That's 605 hours. And we tracked miles because it was just fun to see. We walked to Texas, right into the Texas border. That was huge. But really the biggest result we saw by far was that our community, we created community within our groups. We met new friends, we reconnected with old. We just created this wonderful sense of community among our groups, and many are still walking after the sessions end. And that was our goal, to create these support groups that would keep people moving when we stepped back. So the little stroller strider mamas, one of the mamas had a baby, showed up like the last week of the walking group, and all the mamas gathered around her and were helping her try to figure her double stroller out because this was her second child. And they were going, oh, I got this at home, I'm going to bring it to you. And they're creating a shower for her. So that was just one example of that friendship that occurred across the board on that. So what's the future hold? Oh, for us, one of the things we discovered during our walking groups is that we were trying to encourage people to go to Better Bones and Balance, which is an OSU class that helps for osteoporosis and obviously balance. Some of our members couldn't do it. It was too advanced for them. And so Carol and Christy came up with this idea, well, let's do a limited mobility exercise class and get them to the point where then they can attend to other community classes. So August 23rd, we partnered with Cook County Library, and we're going to start Mobility for Life. Very simple exercises that Rebecca Schultz, that does mindful movement, is going to teach. And it's going to be in the wrap room in the library. So this is a pilot project. We're going to see how it goes, but we already have 5 people interested. We really haven't put it out much yet. So we're pretty excited about that. This will be chair style exercises. A little music, a little fun, again, opportunities for our partners to present for like 5 minutes after the exercise session. And then we're going to have a social where we'll have teas and healthy snacks for our participants, again, to create that support system among our attendants. And so lastly, what do we have coming up in the pike? We are working on nutrition security, both regionally and locally. We have a Harvest and Heritage event we're working with. We're part of the Research in Oregon Community Review System, where we are reviewing grants for rural communities. So a grant comes in, we take a look at the grant criteria or what their process is and give feedback on how that will work in a smaller community. We're also working on a children's activity book that will hopefully be distributed to kindergarten and 1st grade throughout Cook County to teach them about gardening, how that's healthy for our bodies. how you share the food with your family, your neighbors, and even the friends you don't know by providing it to food banks. And maybe even your animals that get overripe, and then compost it. Lastly, what can you compost and how does that give back to the earth and create that cycle again? So we're using a local artist for that and working with Public Services on that project. Deschutes Land Trust has Ochoco Preserve, and they're trying to do some trail connections that are really important to our community. So we're keeping close connections on them with that. And we've talked with LaPlante on how to organize a similar on the move group in LaPlante. It may not be called on the move, but it's structured after what we're doing. So we're excited that that's going to be replicated in other communities in Central Oregon. So with that, we'd like to open up for any questions. We're a little bit over time.
I just want to congratulate you, doing fantastic work. So thank you. And I'm curious to know, I didn't see a whole lot of people who appeared to be Latino in your photos and in your activities. So I'm just curious if you're getting much participation, if you're inviting the community in Spanish.
We are. We were very excited that the Latino community participated in the community garden event this year. We have 2 members regularly attending our meeting. We were going to participate in their Latino festival this year. And we're translating many of our events in Spanish. Right now, our Mobility for Life is being translated so that we can get that out to the Spanish community. We've been working on a long time. We're excited that we finally.
Yeah, we actually saw a real increase in the number of Latino participants this year at our community garden event. We were really excited to see that.
I just wanted to compliment you on all of this collaboration, and specifically around the food insecurity problem that we have in Central Oregon. Everyone, I think, is so focused around houselessness and not recognizing how food insecurity is a part of that system that can lead to increased houselessness or decreased health. And one of the projects that I wanted to make you aware of, if you're not, I know that you're working with the nonprofits you mentioned here around what to do with unused food. And Neighbor Impact serves over 50 different community nonprofits and county health departments in the 3-county region to operate the food warehouse in Redmond. And it's way too small. And so they're expanding that. And the Rotary clubs in 3 counties have been raising money. Over $70,000 is committed right now to finish the last brick of the warehouse, which they've already started construction. So your capacity to store more here locally through the warehouse is going to grow even bigger. The other piece I wanted to mention that you really, the excitement that you have, and we talked about all the new friendships that were made, the collaboration that you are doing, regardless of whether it's food insecurity or any of the other projects, I think is what a huge piece of what people want and need to start to address community divides. People feel so separated and so isolated. And seeing how easy it is to participate in a project with other people in the community committed to the same thing is really powerful and gives our community hope. And so I just wanted to thank you for that.
And I just wanted to mention that we do have regular conversations with Neighbor Impact. As a matter of fact, they might be getting really owie about how often.
Good.
Other comments? Oh, yes, sure, take it right ahead.
I would love to learn more. My name is Trisha Valder. I use she, her pronouns. I'm the CCO director for Central Oregon. Be part of this work and see if that there aren't, I didn't see a lot of financial slides along the way, and I'm amazed with the work that you're doing. I think we're working on establishing a metric in Central Oregon for belonging. And I think when I see this work as the other side of that coin is loneliness, I just really applaud that elusive, how do we attain this by bringing moms together with seniors? It's really incredible. And I'd love to be more of an active part of this work as the CCO, and that's either myself or a member of our team. So I will give you details. Thank you for all of your
We do meetings both in person and a Zoom component, but we also have very detailed minutes with hyperlinks. So if you can't attend, you can stay engaged in what we do. And that's been very helpful for us to bring people in. And we have a certain passion and we have an effort that's ongoing now. Those calls and go, hey, I see you're doing this. I want to be part of it. So yes, if I can get your card, I will add you to our list. We don't bombard you. It's like a couple of emails a month. So, yeah, there you go.
I'm not missing
To
this
add you to the
chance.
list.
We're stars.
Donna, I just wanted to thank you for coming here today and sharing the nonprofit and all the good work you do in. I think it's important to elevate all the good work that's not always seen. And so I think you've been seen today. So thank you.
Thank you so
for
much.
all your work. And
Yes.
hopefully
He's the star of the tattoo artist. We appreciate your partnership too. Thank you so much.
Okay, well, that's exciting. Maybe we should turn over more parts of the system to a small group of dedicated ladies to get things done. All right, next we have the psychiatric residency program. Nice to
Oh.
see you. Come on
Hi,
down.
thanks.
Yeah.
Thanks for inviting us. Janelle was on her way over, Dr. Lewis from Madras, speeding in her Suburban.
Would you like us to put someone in front of you so that she can maybe get a drink of water and you can?
Sure,
You bet.
if you want, if that's
that-
possible, that's,
Yeah, absolutely.
okay,
I hear you.
yeah, okay.
Yeah, $50 to Jefferson County and we can really move the agenda. Just kidding. All right, so Kat, do you mind if we go ahead and have your presentation? Does that work? Excellent. Okay, so we're gonna have a report on the diabetes and behavioral health grant and update on the program. Great to see you.
Yes, thank you. Welcome. My name is Kat Mastrangelo and use she, her pronouns. I'm the executive director at Volunteers in Medicine. So just to get everybody grounded on who we are, in case you don't know about us, we are a free clinic that is powered by volunteers and we provide healthcare to low-income uninsured patients. Currently, that is 95% plus Latino patients who are also Spanish speaking. With support from the Health Council 2 years ago, we were able to increase the quality of care for our diabetic patients by adding a bilingual, bicultural, both counselor as well as an RN care coordinator to our program. So our RN care coordinator is really the lead of this, and she leads a multidisciplinary team. And you'll notice the asterisks on there. So this is a combination of both staff, contractors, as well as volunteers who are working on this team. We include on that our medical director, our counseling contractor, 3 volunteer endocrinologists, 2 ophthalmologists, several PCPs that are also engaged with these patients, a bilingual, bicultural nutritionist, as well as a long-standing volunteer diabetes nurse educator, and an exercise volunteer who actually also is a patient. So by the numbers, sorry, this is so small, but through this grant, we have served to date 385 patients. And that's broken out to 175 diabetic patients and okay, thank you. And 210 pre-diabetic patients that we have added on this year. Our average control, so patients above a 9 on their A1C is only 15.4%. And then 48 of these patients have also received mental health counseling. And so I just wanted to point out, like, is how many patients, 175, is that a lot of diabetic patients or not? So keep in mind that we serve about 1,000 patients at any given time. And our diabetes program is comparable in size to what we have in the CCO for Summit at 213 patients in their denominator, Lapine at 195, and Caldera Family Medicine at 98. So it's a comparable sized program. So it's been an ongoing process. We are a learning organization and we have learned some really important lessons combining mental health with diabetes to date. Excuse me. So originally, we We thought we would do a PHQ-9 on intake for patients that are new to the program. Coming in, we would just give them a PHQ-9, let them be self-reported. And almost all of those were reporting very low scores or zeros. But knowing these patients and knowing their life stories, we knew that that probably wasn't accurate. And so when we would engage with the patients, and then we would give them the PHQ-9 again several months later, their scores would actually go up. But that was because they were engaged in counseling, they were learning more about their situations, how to put language to what it was they were experiencing. And so when they went through this process again, that's why their scores would go up, but with continued engagement, they would go back down again. Another really important, one more point, sorry, is that there is definitely a reluctance to counseling as a separate program, as mental health separate from physical health, especially with our patients. And so the way we have overcome that, the way we learned to overcome that was we have a lot of educational opportunities, and that is just a very culturally appropriate way to work with people and get them to engage. And we would have the two counseling contractors that we had come to those events, and they would participate. They would share the meal, they would participate in the education, and they would also get to know the patients. And then they could tell them a little bit about who they were and what they did. They could even participate in some of the teaching to say, hey, I'm gonna give you some tips on how you can identify stress and what you can do about eating well when you're stressed, that sort of thing. And so through that process, the patients became much more open to receiving the counseling services, and it was a quicker transition. So anybody who's encountering mental health services for the first time, there's that period of time where you have to get to know somebody and they need to get to know you. That period was accelerated. So that was also a bonus. Okay, now next. Okay, so we have also leveraged the investment that you all have made in our clinic. So we got a significant grant from the Marine Lantham Foundation, and we used it to augment our program to include continuous blood glucose monitoring. Oops. That's it.
Continues.
You can keep going. That's it. Okay, here we go. Thank you. Okay. So this was a smaller cohort, and we really focused on patients that were not controlling their blood glucose well. So we had 7 type 1 diabetics and 10 that were type 2. And their starting average A1C was 10.24 in this group, with a range of 7.7 to over 18. And so what we did with this program, every 3 months we were retesting, and the patients were using the continuous blood glucose monitoring. So after 3 months, that average went from 10.24 down to 8.65, with a range of 6.4 to 11.1. Going from an 18 down to an 11, you can imagine it's very dramatic. We did have a couple of patients whose A1Cs were higher after 3 months. And that seems a little counterintuitive, but life happens. Stressful things were happening in these patients' lives. We knew about that. This was not unexpected. But then we did have 14 of the 17 who did have lower A1Cs after this 3-month period. So this is really important. We tracked them over time. So the initial reading, 65% of them were not in control. And we used the same definition that the CCO Quims use for being in control or out of control, which is that break off of 9. So the initial reading, 65% were not meeting that. After the second reading, 41% were not meeting it. And by the time we had the third reading in 9 months, only 15% of our patients were not in control. And so the QUIM target, to keep this in given perspective, is 24.8% not being in control. The most recent average for the CCO is 26.8, so we're really close to that. And the range on different clinics in our community contributing this data is 16.9 to 31%. So we compare very favorably to the clinic that is doing the best. I believe that's the high. So we know that this continuous blood glucose monitoring is really effective, especially with our patients, because what it does is give them immediate feedback. So we can do all the education we want to. We can explain the connection between food and blood sugars, and exercise and blood sugars, and stress and blood sugars. But having that monitor there And having our nurse care coordinator, she also has access to the data. It goes onto an app on their phone. They can share that with her. She can immediately see when we're having spikes. She can reach out. She can have conversation with them. Hey, what's going on? You know, oh, we just went to a birthday party. I couldn't resist birthday cake. Or, gosh, I just found out that my mom died, and that's all I'm focusing on right now. But we were able to talk through that and have healthier responses, and in real time, really get that information. So that would be a pitch for having every diabetic patient have access to that. Right now, it is not covered as a benefit on OHP. It's very limited who can get those blood group responders. We also had another program that we used this cohort of patients, and that was dental care for diabetic patients, because we know that the mouth is part of the body. And if you have good oral health, then that's also going to help with blood sugars. We had that was funded by the Central Oregon Health Quality Alliance, or COQUA, which is kind of an arm of COIPA, Central Oregon IPA. And so with this partnership, we reached out to Capital Dental, and it's an ongoing grant. It's still open. We haven't finished it yet, but we had a wellness class that Capital Dental came in and supported, and we had education. We gave all of the participants electric toothbrushes as well as water picks. And part of the class was learning how to use those, experience what that felt like in group settings, so they could talk about it and then talk about the importance that this was going to bring. We had 12 of the 19 patients by the midpoint who had those visits. And what was really interesting, we like to start with just doing a really good cleaning. And so it started with a dental hygienist and a cleaning, who would then identify different areas that were going to need some attention. Almost all of these patients had something else that needed to be done. Cavities that were unfilled. A lot of them had pretty significant gum disease. But after being a part of this program, using the water picks, we were seeing a lot of results from that. So we treated this. So this is important. This was a conversation just last week at the QUIM work group, which was, how do we get patients in dental? How do we get these patients to get the intake on their dental, right? Because we're not meeting that QUIM right now. And what we found was treating dental like any other referral to a specialist, having it start with the healthcare team that already knows this patient to say, hey, you need that, you haven't had this, you probably need it. We've talked about this. We want to send you to this dentist. Here's the dentist we want to send you to. Here's where they're going to be. Let's get you on the phone with that office. Let's get all of us on a call so we can set that appointment up for you. That was highly successful in engaging these patients. Took a little more work on our side as the primary care office, but the results, I think, speak for themselves. So this is kind of that lesson learned. Having the clinical staff make that warm handoff was really important. And then she could also reinforce that as she was calling them, hey, you know what, you need to come in for your lab work. By the way, how did that dental visit go? And they could have that discussion. That was also very supportive. Mental health supports for patients that were very anxious. A lot of times trauma shows up and reluctance to have dental care. Let's see. The cleanings were really important. The patients, even if they didn't know about anything else, they knew that they needed the cleanings for their teeth. And then this is not something I'm telling anybody, but we need more dental capacity for the high needs patients. We have patients that, we're going to end up pulling teeth because we can't get root canals. And that doesn't feel good. And at least we're getting care. So this isn't part of this grant, but I also wanted to take this opportunity to talk about this. So the Healthier Oregon program and the transition. So you guys might hear this hot. So we have 63 diabetic patients out of that cohort of our 175 who are transitioning care to another safety net clinic because they now have OHP, and 14 of those had an A1C above 9. So only 14 out of 63 uninsured diabetic patients with an out of control A1C. That's a good number. That number means that our whole healthcare system is able to reap the benefits of those savings. It's been shown from other studies in other states that when patients have not been insured and then they get on Medicaid, it takes about 2 years for those costs to even out to where they are at an average, because there's just so much that hasn't been done. Patients that are going to be transitioning from volunteers in medicine are not going to have that 2-year lag. They're going to come in at their average right out of the gate. But we are seeing some churn with OHP eligibility. So with the presumptive, any patients that had Callum were presumed to be eligible for OHP. Many of them, didn't know they had Callum, so this was a surprise to them. They show up for, they want to get an appointment at them. We're like, oh, you can't come. You've got OHP now. Let's talk about that. They're like, what are you talking about? I couldn't do this. So there's that piece, but then a lot of them, their Callum eligibility is so old and dates back to COVID times that now, the economy is doing well. They have jobs. They're above the 138 for Medicaid now. So they're not going to be eligible for very long. They're going to roll back off. Well, in the meantime, we have patients we have to kick off for a month or two due to our agreements with our pharmaceutical companies and the donated medications. That's not enough time to establish care anywhere else. So in the meantime, we're in this limbo. It's not really serving anyone very well. So we're kind of stuck with that right now. So any questions? I talked fast. Yeah.
Yeah, number one, thanks for engaging dental in your project. We did talk about it in the formal group. In context of trying to meet the metric,
right.
But more important than meeting the metric is the opportunity to improve health overall. And the importance really of bi-directional messaging is, as DCOs, as providers, we can call gap lists till we're blue in the face, and we call the same patients over and over again, trying to encourage them to come in for their dental appointment, and so we can improve their diabetic health, their glycemic control. And we have as we talked about it, very little success. So the messaging from the medical side and behavioral health too reinforces that. And I also want to comment that dental access continues to be a problem. Even with redetermination in our own DCO, our overall enrollment is growing. It's not decreasing. And so it's going to continue to be a problem. But there actually have been a couple studies, and one that was published just recently, that a simple matter of brushing your teeth will help with glycemic control. Certainly the cleaning of your teeth, the deep cleaning for patients that have periodontal disease is going to be very beneficial. But even without access, if we get toothbrushes in their hands, and we ourselves, Capital is providing electric toothbrushes, and with health-related services dollars, we're providing electric toothbrushes, partly as encouragement for them to come in for their check, so we can meet the metric, but also to improve their overall health. So again, appreciate that you engaged down this part of this project.
Yes, and then Dr. Shakur.
You called out a phenomenon that I think is right. That is that when you're looking at outcomes for people getting sometimes at the 3 or 6 month point, people look worse. We found the same phenomenon in our CCDHC data. So we would have people fill out a national outcomes measures survey that asked about lots of things. And what we saw is that new patients would report lower levels of things like depression, substance use, and violence. And then at the 6 month point, was level. We had to track here to see declines. And by the way, we did see some. The reason I'm highlighting it is both validate your experience, because we have it too, but also to say that we often see behavioral health services as the kind of immediate fix for problems. And what we know as clinicians is that there's that relationship building that occurs in a behavioral health setting that people sometimes roll their eyes about. Talk about the how long it takes, because we don't know. And we aren't, we're not necessarily quick fixes, other than crisis services for some of these long-standing issues. So we've got to hang in there took part to treat for enough time to build trust. Think about your own relationship. How long it might take you to share something. So I really appreciate you calling in.
Yeah, early on, James Denver studied one of them on falls, actually. Improvement projects. One of them was on the falls, and the other one was 7 counties in Oregon. Where we actually found that the only particularly significant thing, because improvement in health issues like this is case management. And so, if you have a lot of people that have diabetes, with a lot of people have other issues, if you help case management, because dentistry is not geared up for case management, they're geared up for fixing teeth. And so, I don't, whoever is responsible for case management in the overall CCO system, an emphasis needs to be made, which I see is good, to case manage. We all know that people who have had an adverse childhood experience end up with all kinds of health outcomes that influence their life based upon a lot of things, equities and all kinds of stuff. And so their belief systems, the way they think about things, don't necessarily fit into what the things that they think is normal. And so case management, the 2 studies were done, Gary has access to, that have showed that case management is the only statistically significant thing.
Well, and I think that's the beauty of this program we have is this RN care coordinator. I mean, that's effectively what she's doing. She's on the team, but that's what she's doing, and that relationships the patients have with her. And her, if she tells them, hey, I think you should go do this, or we need to get your referral, they trust her, and so they'll follow through.
We had a group of 44 severely stable people that they were having a hard time getting access to care to. And what we did is we assigned one pediatric specialist who did labor folks and to go and examine them all and then treat them with a lot of people and get management and then keep them so they didn't have to have all the issues that go around that. Being the point of case management we're talking about, that sometimes you gotta look at, as you all know, you have to look at the group of people with their special needs and how to case management so they get the care they need rather than trying to mainstream systems. Isn't that?
I just wanted to add thank you for this work. This is a result of the behavioral health shared savings strategy 2 years ago. And I guess my question is, you put integration in this model and this pilot. So how can other health systems embrace, these statistics or, this work? I don't know how we carry off pilots and start integrating them in other systems or other healthcare systems. Well, I think having the embedded mental health has been important for us, and having a designated person who's kind of our go-to. And then she's also a part of that team, that care and coordination team. And so they have meetings all together and they're all discussing, all of the patients all the time. Hey, we're struggling with this one. And, education comes in here and nutrition here and then the mental health piece there. And they're all reinforcing the messaging. Finding someone who was bilingual and bicultural to do mental health services we were fortunate that the individual we have had done her mental health counseling internship with us. And so she was very familiar with us and we with her. And so that felt really good. With patients that speak English, I would hope that, identifying a couple of people who are willing to do that type of thing. The other thing that we did on this that was a little different is we just bought hours of her time. Okay, here's where you're going to be at the clinic. And then if patients didn't show up, she still had the motivation to be there for the full time. She would use that time if somebody didn't show up to engage with other people, make phone calls, that sort of thing. And so I think this, kind of kill what you eat model, where if somebody doesn't show up, you don't get paid. And now you're reluctant to take on that patient, or it takes a while to develop that trust. I think that's part of the success of this program, but it's a little bit of a leap of faith to be able to do that when you start talking real dollars.
That's
Also hearing that we have some relatively low cost interventions that are not covered, the glucose monitors and some other
So
things,
for a
they
full
could-
year, it's, the monitor itself is not super expensive, but then getting it's every 2 weeks, you gotta get the new, whatever it is. For a full year, it's about $2,000, but even just doing a couple of months, letting people understand and learn that. Some of our patients really just need it ongoing. Other ones are like, okay, yeah, I got it. I can do this now, but other ones just, as soon as we took it away, it went right back up. Yeah. So. with that.
I was at a presentation by, the director of the Deschutes County Library a couple of weeks ago. He was talking about the construction of the new facilities. And he mentioned that the purpose and the real focus of the facilities are to be more community friendly. The creative uses of the room that a traditional library might not quite think of. And I talked with them about what's the possibility of using a room or two for behavioral health services for low income people. Or for people who, for one reason or another, can't get to an office or something like that. So that may be true in other county libraries as well. So I just wanted to share
That's
that
great.
connection to stretch some creative thinking about how to expand your services in a pretty affordable way.
Do you know when they're supposed to have that finished? Do they have an estimated year?
There's 3 or 4 facilities.
Okay,
It's at least.
at least a year. Okay. Thank you.
Great job.
Okay.
Thank you.
Thank you. Thank you.
Hey, residency program. Come on down.
Thanks again for inviting us to do this, which is awesome. I introduced myself. I'm Rob Ross. I'm a family doctor. I'm the director of education and research at St. Charles. And if you don't know Dr. Lewis, she's very well known in Madras and was a resident of mine and student of mine in Klamath Falls way back.
Yeah.
And moved to Madras. So she is actually officially the first residency director in Central Oregon. A good one she will be. So what I plan to do is just not just talk about the psychiatry residency, but a bit about the rural training program, which is starting in Jefferson and to some extent Crook County next year. And so by way of my experience, I was in academic medicine for 28 years and worked for 2 different universities. One is a program director in Edmonton, and you may wonder, how does a Canadian get to the United States? Well, it's actually historically interesting because the Flexner report from the early 1900s reviewed both US and Canadian medical schools, and since that time, both have been accredited so that you can move between countries, as have the residency programs. So it's relatively easy to come here as a Canadian and vice versa. Many of my colleagues in Canada were American trained. So, and this is I really consider this a community strategy to build residency programs. And I love this saying at the bottom, a town is just a town until it gets a college, then it's a college town. And a hospital is just an ordinary hospital until it's a teaching hospital, essentially, and then it's extraordinary. And I truly believe in that. So next slide. And just a bit of history about medical education. So, doctors start their careers going to college. That's usually 4 years. And then they do an MD or DO degree, which is another 4 years. And residency comes after that. So they're actually graduated physicians. We call it graduate medical education. It really should be called postgraduate medical education. I've never quite figured it out. Anyway, but this is what is happening. And congratulations on Prineville being the fastest growing. I don't know whether that's good or bad either. But I drove down the canyon I do this when I come out here when I have time. And thank goodness we live in a beautiful part of the country and the world, right? It's just amazing for her. That's okay. So in case you didn't know, the population growth is huge in the Tri-County area. I think the projections from Portland State are woefully inadequate and very understated. We already have physician shortages. If anyone has tried to get into a primary care physician's office in Bend, it's at least 6 months, according to what I know. There's a real need to address the social injustices and the maldistribution of rural care, obviously. And that was the main reason why I moved to Klamath Falls to do the residency there, was that was clearly an underserved area. In academic medical centers, quality, safety, patient outcomes, care is better. It's been shown over many studies over many years. And we want to be part of, innovation and provide the population for the future, because, in 2050, we're probably going to have to look at having a medical school, expanded nursing school, tech schools, all these things, which were fortunately in place in Klamath Falls to some extent, but less here. Anyway, next slide. Get it. I talked about the population growth and provider shortages. It's not just PCPs, but the best example, so primary care physicians and access to clinicians in general. But the Association of American Medical Colleges put out a report in 2020. And the projections for Central Oregon are a shortage of 220 primary care physicians. So that's for the Tri-County area. I think that's an underestimate, because they really didn't count the people that are in other jobs, nor did they account for retirements. And I've talked about improving access, quality care, mortality rates. All these things get better when you have medical education in general, but especially graduate medical education. It also creates a great pipeline for hiring people here, because it's not just primary care physicians. I can talk about psychiatry. I had no idea that the state of Oregon is in until I started working on that residency. But maybe even more importantly, as far as culture in a hospital, and I've seen the incredible transformation in 2 hospital systems. When you add residents, it just makes the staff and the people and the nurses and everyone much happier. And it becomes a much more joyful place to work. And if we need anything, we need a little bit more joy in our lives. Next slide. So I talked about OHSU and St. Charles being in a partnership. So Janelle is part an employee of OHSU and part an employee of St. Charles. And that's the way these residencies are going to be designed, or intentionally designed that way, for many reasons, because linking to an academic medical center like a big university improves the quality of training and attracts better faculty and residents. And so the financials for the different programs are somewhat convoluted, because the federal financing for residencies is totally convoluted, always has been. But basically it's a partnership with OHSU being the educational sponsor and St. Charles being the host institution. Next slide. So the rural training program in Madras. Janelle can tell you all about her visit to Kansas City. Was it warm?
Yeah.
Thank goodness I don't go back there 5 times a year, but it's a great city. But so she was at the American Academy of Family Physicians Resident and Student Conference last week. And I'm sure she can tell us how many people were interested in spending their first year of residency at OHSU and then moving to Central Oregon for their 2nd and 3rd years of residency. So this effort was supported by HRSA and a how-to state grant, which we're very fortunate to get to the tune of 1.75 million. And that doesn't really cover the total cost of developing a program. And thanks to the generosity of Central Oregon Health Council, we got $500,000 last year to try and start developing the psychiatry program. We've hit a lot of bumps along the way. I can't get into it, but because of the federal funding rules for the hospital, things have changed over the course of developing this residency. And right now, we're very engaged with Ron Wyden's office, and they've been great lobbying to get certain rules changed, not just for Central Oregon, but for rural America or semi-rural America as a nation, because this is a huge barrier to training physicians of all stripes. So we're working on that. We did hire a program director who's working. He's the associate program director at OHSU and a wonderful person to work with, Dr. Stanley. And this month we're finalizing accreditation application. The ACGME is the Accreditation Council for Graduate Medical Education. And you have to apply to them to get your residency approved so you can receive federal funding. So we're almost done that little thing. And thanks, Rick, for partnering with us. Hopefully we'll get, and many people in the community partner with us. And so I hope we're on our way to actually becoming an academic medical center, because we have undergraduate medical students, we have nursing students, we are just lacking residents until next week.
Oh, this is mine.
And that's it.
I don't know if this handout is in her. It is folders. Okay, yeah. So I just want to give like a general overview of the program. And Rob touched on a couple of things, like the fact that medical students do their 4 years at a medical school, and then there's this big conference in Kansas City where students can attend this big conference with most of the family medicine residencies in the country have a booth there. And so we went a couple weeks ago to Kansas City and set up a booth to recruit medical students from all over the country to our program. So people were coming up to us at our booth who had already looked at our website or following our Instagram, which is pretty wild considering we have no residents yet. We're a brand new program, and they were coming up and knew all about the program already. And so there's a lot of interest in rural medicine right now. There is growing interest, including at OHSU in Portland, in family medicine, which is really important with the shortages we have in primary care providers in family medicine in general. So I think this is an exciting time to really build that, because that's what we need is more family doctors. But this big conference we recruited, we ended up talking to about 45 medical students. So we tracked all of them so that we can keep in touch with those who might end up applying to our program. The application process is going to open in September 6th through the 27th. There's a big system where they apply into our program, and then we review all the applications and decide who we want to interview. And we plan to interview around 48 medical students for the 3 spots that we have for the first year of residence. And then they're going to start in Portland next June. They'll do a 2-week orientation and then hit the ground running, doing their clinical practice in Portland for a year, and then arrive out here in Central Oregon, primarily based at St. Charles and Madras, with 3 different continuity clinic sites. So their continuity clinic is where they see their base set of patients that are assigned to them as their primary care provider. And they'll follow those patients for the 2 years that they're in Madras. And we'll have 1 resident per year. So we'll have a 2nd year and a 3rd year in Madras, and there will be 1 per clinic at St. Charles Family Care, Mosaic, and then Indian Health Service is also partnering with us. So it's a really neat collaboration, not only with OHSU and St. Charles from the hospital side and the education side, but also the 3 clinics coming together with Indian Health Service, Mosaic as FQHC, and then St. Charles working together to support those residents once they're in Madras. And then they'll be doing a majority of their rotations in our hospital over there. All of the community physicians that work in our hospital have agreed to come together and work to teach those residents. And then they will do a couple of rotations over here in Pineville, hopefully 1 in the emergency department over here. We want them training in rural sites because we're training rural family doctors. So the goal is to get them out into rural areas, hopefully in Oregon, but some may be transitioning out to places like Burns, Enterprise, Wise, John Day, Ontario, Baker, that are more remote where they are working in the ER. It's really important that they get experience at a critical access emergency department and train in the environment to be prepared to go somewhere even more remote. And then they're going to do a gynecology rotation over here with the Redmond Women's Group. But the rest of their training should be mostly in Madras and at our hospital. So, and I think there's a couple, I don't remember if the quotes are on here, but what we know is that the majority of residents end up somewhere, I think it's like 75% end up within 100 miles of where they train. So there's actually a large contingency of physicians in the area, including myself, who trained in Klamath Falls. So Rob was program director when I went and did a medical student rotation down there. I also did 4 rotations as a medical student. I came from Portland. I wanted to get the heck out of there. So I did 4 rotations in my 3rd and 4th year of training in Bend. So I did ICU, psychiatry, neurology, and general surgery with Dr. Mastrangelo. So now I went all the way full circle. I went down to Klamath, did my training, did an ICU rotation in Bend again, did NICU in Bend, and then ended up in Madras permanently. So I've been there for 9 years, and now get the opportunity to start teaching at a different level with the residents. But there's quite a few physicians here in Prineville who trained in Klamath as well. And then I recruited a graduating resident from Klamath Falls to work with me at our clinic in Madras as well. So we're hoping that out of our class of 3 each year that we retain at least 2 of them somewhere in the area or maybe more remote in Oregon. So we're kind of starting the process of growing our own physicians.
Such a great example of growing your own. Klamath has actually supplied a lot of rural physicians. Like we did a study 10 years ago and 64% were still in health professional shortage areas in Oregon. So if you train them here, they stay here. You went through undergraduate, graduate medical education. So the more time you spend in rural areas and the more time you spend in your state, the more likely you're going to remain there as a practicing physician, which is one of the reasons we need to have a psychiatry residency, because I think anyone who's clinical here knows, like, you can't get in to see a psychiatrist, and there's certain patient population that desperately needs that help, whether they're engaged with behavioral health or other things. And, it's impossible to call a psychiatrist to get a Medicaid patient in to see a psychiatrist. I mean, it's just, it's pretty bad.
I got confused partway through your presentation about whether what's being proposed is a residency for family practice versus psychiatry.
We're launching both at essentially the same time, but the family medicine residency started the planning process and the grant writing a lot sooner than psychiatry. So Rob helped write grants for both programs. And our program for family med is going to be based out of Madras, and the psychiatry residency will start and be fully in Bend.
Okay. And then just a follow-up question. You mentioned housing. How are you going to provide are you going to provide housing or expect the residents to provide housing in this market?
Yeah, that's a great question. We've had actually a lot of meetings with just different local planners, realtors, and people in property management to try and plan ahead for this. Rob has been on the ball with that ahead of time. And our numbers were a lot bigger before, but now we're at 3 per year because that's what we feel like we can accommodate with the 3 clinics initially. And we're going to see how it goes and see if we need to grow it. But there's some new housing being developed in Madras right now, quite a bit actually. And we have those property management folks involved, aware of us. There's also a time period in their first year in Portland where they're going to come to Madras for a week. And so and that'll be 6 months from the August timeframe when they're moving over permanently, where we're going to get them dialed in with a realtor 6 months ahead to start looking at property that week or rentals, anything that's available. And so we have that all kind of dialed in.
They'll be expected to pay for their own house.
Correct. So there's actually a problem because they are part of a union currently at OHSU, which is in renegotiation. So all the residents that are at OHSU are part of a union, therefore our residents are going to be part of that union if it gets renewed. And
we can't do anything for our residents in Central Oregon that is not being done for the residents at OHSU. They do not provide housing for all the residents that are at OHSU, so we can't for our three, unfortunately.
No, you have to look, the residents are making reasonable money. They're
What's reasonable?
reasonable is about 60,
It's like 55 to 60.
yeah, 55 to 60 in their first year and then 62. But I want to tell you that housing the positions here is terrible. We had 2 graduates from GME programs in Midwest wanting to move to Central Oregon. One was ICU doc and one was an emergency doc or something. They simply couldn't afford a house in Bend. I mean, that's pretty bad. They had student loans and their salaries are obviously a lot higher, like 200 to 300 or more, and they couldn't qualify for a mortgage. So it's like,
And teachers and law enforcement.
oh yeah, no, I mean, you've got to feel terrible. We can't support the service people that live and work in Central Oregon.
We just did a grant, but it's unfortunately, it's only $500,000. It's 30,000 to each house to be built in like the 300s. But we just did that funding for this year and hopefully it'll happen again next year for the kind of people that you're talking about. So, maybe things turn around, we can double that or triple that or something, so that we can get more houses for workers.
Has St. Charles looked at all? There's a program the school district's using here where you get like an acre of land and then they have tiny houses you can purchase. And then you actually just purchase the home and the company owns the land. And then you can, you're able to sell it down the road for like a small increase.
Yeah, I'm not sure where St. Charles is right now in terms of housing. I mean, back 3 or 4 years ago, there was some interchange between people who developed HUD housing for various hospitals throughout the nation. And I think it was at the time, it was just before COVID started, so I'm not trying to throw anyone under the bus, so it was a pretty difficult time. And then recently, I mean, we have been trying to get our financial footing under us again, so that would be a possibility. I know there was talk about exchange of some land to develop some low cost housing, because it's true of nurses, techs. I mean, even though they're relatively well paid, 100,000, whatever, they can't afford to live in central, basically central Oregon.
Yeah, we've been working locally just in Madras. I've been meeting with the city, the county. I've been working with the Bean Foundation to see about donation there. They threw out the possibility like, hey, if we donated you a house, like, would you be able to use it in some way? And the answer is we can't provide, like, we can't just give the residents housing 100%, but we could, if someone donated a house and there was a way for them to pay a small amount of rent, then we're not giving them free housing. So there are workarounds that we're looking into with things like that. If we found a donor that was willing to help out in that regard.
I know the Boroughs just built a brand new double wide manufactured home, really nice gated community in Madras. And I'm not sure if it's actually opened up or not, but they're great people to work with. They're actually looking at doing something in Terrebonne and in La Pine, but they seem to have a really compassionate spirit about them. So you might want to look up their mobile park that they just built.
So the irony is that 60 years ago, I was living in hospital supplied housing that my, that's what they did with physicians at that time. So, yeah, we're just full circle.
Well, that's why they were called residents. I think in my day, I basically lived in the hospital, but that's all changed.
There's now work hour restrictions.
Yeah, of course, yes, that's how it works.
Question, given that Madras is 35 to 40% Latino,
Yeah,
are you gonna prioritize that in your recruitment?
we're hoping that yes, if we get candidates. I think I talked to one person that I recall at the conference at the 45 I talked to that said they were fluent in Spanish. And so if we get applicants that are Spanish speaking, that would be excellent. Just depends on who we get.
Yeah.
who's interested in our program, but we are definitely marketing the fact that our community is culturally diverse with a third Native American, third Latinx, and third Caucasian other. And we actually have a medical student. We actually recruited a lot of people that are in their second and third year as well at this conference that are going to come through next spring for a rotation to check out our facility, check out the community. And that's where we're getting a lot of interest is we're having a lot of visiting medical students come work with us for a month. And we take them out hiking. I throw them on my horses, take them to any event I'm going to with my children. One, let my son practice pitching to her, and she never played baseball in her life. We take them hiking. We do anything, take them to the lake. We have a medical student from Texas right now. So all the Texas students are trying to get the heck out of Texas. So they were at all of the Northwest programs looking because they can't train in women's health the way that they want to in Texas. So they are all literally, there's a mass exodus of med students out, and they have 7 medical schools at least in Texas. But she's here, we're going to the circus tonight. So we just take them and show them whatever we can. And that's how you recruit. Like that's what happened to me. I went to Klamath Falls, worked with the whole group. They took me out up Mount McLaughlin. Carrie Allen tried to kill me. And then I ended up in Klamath Falls to train, and Rob Ross recruited me up here. So I just am following Rob Ross. So hopefully I'm going to get these students to follow and take over.
They will.
Yeah.
This
So
is a game changer for our region.
Yeah.
I just want to say thank you so much for the commitment and dedication to making this happen. And Dr. Ross, how long has this been a dream of yours to get a residency program in Central Oregon?
Well, I mean, I'm partially responsible for some of the mayhem with CMS funding, because when I was the program director in Klamath Falls, we triggered what's called a cap for St. Charles Hospital. We didn't know this was going to happen, but then the Balanced Budget Act of 96, 97 came along. So St. Charles was collecting CMS money for training folks like Janelle. And then they decided in their infinite wisdom to not allow any hospitals that had one resident to develop their own programs. So part of the RTP was to get around that. And we could have got around that locally, but it was just very fortuitous that I had OHSU relationships left over, so that, the deanery and the provost and all those other people are very interested in this, and they're good partners. I mean, they partnered in Klamath. And if you drive through Klamath Falls now, take a trip up to Sky Lakes. They've got an OHSU building, a rural campus. OIT is right beside them. They don't have recruiting problems. They got nurses and Rantex. So that sort of dream has been in my head for a while. And, but really, it's been five years trying to figure out how to work around the cap and partner with the right people. And then, in a community that actually rejected the residency, that went to Klamath Falls in 1992, there's been some local, not resistance, just uncomfortableness. Yeah. So, and there's been all these barriers which we're trying to work through.
Well, congratulations, and thank you so much for all that you've committed to doing this.
Thanks.
So we're proud to be partners alongside you. So thank you for the presentation today. Do we have is there other questions or comments?
Appreciation about coming after the psychiatry residency.
Yes.
They're blue unicorns, and so really, really appreciate that.
Well, what was fascinating to me is, like, after we got the rural training program, we knew that, or I knew certainly that there were more than 100 open positions for family doctors in rural Oregon. And in Klamath Falls and OHSU and the program in Oxford, I mean, they're never going to fit. But in talking to psychiatry came up because I started. One, I knew psychiatry. We had no psychiatrists in Klamath Falls, essentially. And we would man their psychiatry ward at night, and all sorts of things. And then I started learning about Oregon as a state. We have like the 48, like not number one, the best in access. We're number 48. Terrible access. And we have some really good ideas about underpinning the seriously mentally ill, but if you're a psychologist or a family doctor or LCSW and you need more help because, 2% of the population or more, as you know, have substance use disorder or serious psychiatric problems, it's impossible to get them care. And so that was the logical next thing. And talking to colleagues at St. Charles. So just to give you an idea, OHSU, their psychiatry residency takes, I believe it is 6 residents per year. There were 57 medical students in Oregon 2 years ago that applied to psychiatry. So the program, they have a program in Salem as well, but I think it takes 4. So out of the 57 that applied, so they rank psychiatry as a specialty. We exported 47 students to other states, and they probably won't come back, right? So we can solve our own problems, but you got to be willing to.
Yeah, you get these complicated cases coming in community mental health, and and if you don't have the full MD plus the psychiatry on top of it to really integrate an assessment and go forward with treatment, and good psychiatrists worth their weight in gold, of those cases. Is you know so well in medicine.
Yeah, no.
Well, thank you so much. Great.
You're welcome. Thank you for having me.
Okay, community engagement strategy.
So we're gonna segue into the community engagement strategy, and we're bringing this up to follow up with some initial conversations that happened at the combined meeting last month. And because it really ties to the strategic direction number 5, identifying and addressing inequities. So it's been part of the story of the Health Council for many years, and OHA has also reoriented their work to focus on health equity as well. So we're bringing it to the forefront for you all again. So you all are familiar with the work that you've done within the Health Council, within the DIJ world for the last week. For those of us who've done this journey, we know that it's a journey. It's very independent. It's very individualized. It's based on our own stories and experiences and exposures. And that's the way it works in an organization as well, the Health Council included. And so you all are familiar with the board role with the strategic plan, as you saw that last month. But there's even a broader story. And the story for the Health Council has started with where each section or each entity within the Health Council was ready to. And started probably back in 2018, 2019. And it's evolved and becoming more aligned. And so we're going to bring you into this next chapter after I kind of orient you to where we've been. So as I mentioned, we started where there was readiness. Where there's readiness means that sometimes there's misalignment, or not misalignment, but people are focusing where they're most skilled and ready and impassioned to talk. And so you can see kind of a little more detailed timeline that I'll leave it to you all to look at how diversity and equity and inclusion has evolved in the Health Council story over the years. And all that to say that coming forward, more recently in the last couple of years, staff have been slowly working on bringing all the components of the health partners and our readiness to moving into the same direction and aligning efforts and structures to strengthen our journey and our work. Miguel is going to be taking us into the plan development. It's going to really focus and strengthen that alignment to enhance our community engagement with really a focus on diversity, equity, and inclusion. That's our core.
Thank you. So
You got it? Okay.
So before going into the plan, we wanted to share with you some
slides that have several concepts that are useful to understand, because the topic of diversity, equity, and inclusion is slightly different to other areas of knowledge, because it's more similar to a value than to just a standard knowledge. So the first aspect is about how the decision context is related to understanding the rules, to a set of rules, understanding that, but the values and life experience plays a major role in taking decisions, because that's the main filter. So and that's what is important, the community participation. So that's the first image that I want to keep in mind. The next one is about that, precisely that equity, diversity, and inclusion is more related to a value than to a knowledge. So it's very difficult to drive change when we need it, just solely from within the organization. And we need to include people with diverse experience to inform this decisions process. At the moment, the numbers that we have at the Health Council is only 5% of the work groups of people, so 9 people are community members not representing an organization. That is the numbers that we have right now. So this next concept, I'm sure that many of you will remember this model that was presented to you several years ago. The conditions about systems of change. So in green, you can see that there are many aspects that the Health Council is doing right now that are at the explicit level. So changes in policies, distributing resources, and also changing the practices. That is fantastic. That is the work of you. That is the work of work groups. But really, systemic change happens more at the 2 next levels. So at the semi-explicit level and at the implicit level. And that is what this idea is trying to impact. So engaging more the community and keeping them basically informed, consulting them, and hopefully involve them and even leading some of the projects where possible. And but obviously our goal is to work on the level of changing the mental modes, working to touch the heart of the people. That is a big challenge. So that is basically the idea, because we already know that the Health Council is a very transparent organization. So everything that we do is public. So, but now we want to go a little further than that, and then not just being transparent, but really open the door, involve the communities in the world. And that is a challenge, and that is what we are proposing with this idea. How well we are proposing that? Basically, it's on. We are following 3 ideas. These ideas were built in coordination with our CAC, in coordination with you, with your feedback that you also provided, and it's basically first, it's everything. It's an idea. So it sounds like a basic, but we need to imagine. We need to imagine another way to create a better and more just society, and this needs to be in our minds, in our spirit, at that level of not just a knowledge, not just something that we understand logically, but we can really live that. And so that's the first strategic direction. The second one is, it's gone. And then the second one is building capacity. So in building the capacity, this work is difficult in bringing, it's gone. From time to time, it's taking break.
Need a wire jiggler.
So the second aspect is really to build the capacity for the work, and build the capacity may look different according to the client or according to the group of people that we are talking about. So for a board, it looks different than we look for our staff or for our community. So every group, every client needs to design their own strategy to advance that according to their needs, right? So because they're different. So that's the second level of
strategic direction. And then finally, obviously, the other part is empower the communities really for a meaningful engagement. And the communities need to be empowered. We need to create the conditions and support them to develop this level of relationship that we want to have, particularly with the informed groups and some committees that will be able to do that. So those are the strategic directions. And now, how are we going to do it? So what we are proposing is these 4 future state metrics. Obviously, the first one comes with making this as a priority. Put that in the minds of all of us that we are working to get on these secondary levels to change the model. But the number 4, it's important for me that you consider that if we go into the community and we try to do that, to at least at these basic levels, to keep the community informed about what we are doing, what are the opportunities, how they can engage, and then obviously consulting them. We have in the middle of the regional health assessment project with a lot of success getting to specific underserved community groups and listen what they have to see. And that has been a fantastic exploration. But it's not enough just to go there and understand what they do. They are asking to be involved. And so that's a big challenge. That's how we are planning to. So there is an ask, obviously, but so the ask is that we have your support to begin to launch this process and begin to build it that will look different according to the different members. And I stop there because I don't have more time. And I open for questions.
So what does that look like?
So, for instance, if we talk about the board, so the board has already, in the last time we talked about this, you talk about, okay, maybe we need more representation than that, or maybe we need another. So how it will look like for the board is that the board needs to decide how to get into this process to become more diverse, to become more inclusive. And the inclusiveness has many, many faces, and you can decide the way that you are going. So we as staff, we can support to lead that process, but you are the ones that you are going to decide according to what you need. And the same for the work groups, and the same for the staff. Yes, first Janice and then.
So Carmen will be familiar with this page. If you want to engage community, you've got to start with the person. We are losing, and you may be doing that in some settings, but people are all going to grow because we're all used to making it work in our professional lives to meet online. I'm here to tell you, we lost people's meaningful engagement. We had involved in community work groups because we had to during COVID. And we do not build relationships and think, I'm sorry, there may be people who want to debate that, but there is emerging research that's showing people are getting disconnected out of being totally working, not being in rooms together, not solving problems in physical proximity to each other. So that's my plea. Totally in support of where you're headed. Get people back together, eating food together, and sharing space, please.
Thank you, Jen.
Yeah.
I'd say ditto. Thank you so much, Janet, for saying that, because it just really, you need the connection in person, makes such a difference. We had behavioral health together. It was required that we all had to be there, and what a difference that meeting had. Yeah.
I think with community engagement, the devil's in the detail and how you do it, because I saw the state's attempt to roll out Measure 110 with their initial oversight and accountability committee was a disaster because they made sure they had everybody but competency on that board. And so asking people with a high school education to roll out, $100 million project is really unfair. So how you put people and how you have them voice is really, really important. And so, or things will get messed up really fast. So there's a right way of doing it. And there's the oversight and accountability committee way of doing it. So I would really think, ask us to really think through savvy ways of going.
We count on your wisdom.
Well,
Thank you.
now we're in trouble.
Katie.
I'm a very visual person, so I might have you go back. Like, I'm seeing language in statement for, yeah, that was. One more.
Forward.
Or one more. Yeah, number 4. So when Oregon Health Authority talks about their statewide equity plan, they're leaning very heavily on community-based organizations that do not exist in rural states. And I would urge us that in Central Oregon to decide what equity looks like for us. And you heard from a fantastic group of people today that are doing great work in Brick County. They are not technically a community-based organization. So if this is language, but language is very powerful, and how we set up a system that implement metrics, and if we say, well, this many people are going to be involved, and these are the people, health equity in rural spaces will be left out if we don't pay attention to that particular initiative that's being pushed to the state level. And if we don't build capacity in the rural communities to address health equity in a way that might be through community organizations or community members that gather in multiple ways, but I would not shoehorn ourselves into language that's being used at the state level, just being used.
Yeah, the first challenge for me is just to inform the community that we exist and what is happening. So that's what is gradual, right? So it's like first inform them, and then, and I totally agree with you that community-based organization is one possible partner, but we have an example today about other ways that it can be done. Organization, but we need to invest on that other side. If we want these communities entering that clear door, we need to invest in that. Thank you.
There's an intentionality of putting money and resources to be able to develop community-based organizations too. So it's not in lieu of, it's in addition to, and I don't want to overspeak for Katie, but it's there's a sensitivity around that because the state is actually carving out money to community-based organizations only. So it could make some organizations that we would all say is a community-based organization ineligible to apply. And so that's the sensitivity in tracking, especially in rural communities.
Yeah, through the RAB, we are connecting right now with 20 different underserved communities. And what we are planning is that use those contacts that we have now to enlarge them and make it more collaborative for us to continue.
Awesome.
Yeah, I mean, the debates that we're having is, it looks like a fine program in the metro area, and the unintended consequences, it will siphon resources into the metro area and starve the rural areas. Because, in Madras, if you want to do a service in behavioral health, you say, oh, we got to do a community-based program. Best care is the only option.
Yeah.
And they're, and so, best care can't apply. And, but there's, 30 of them in Eugene or Portland. So
it's something important for us to track.
it's being driven ideologically with people who have no idea that we even exist.
I just wanted to add that all of this feedback is really where we want to go in the plan, and to involve all this feedback so that we have a board strategy. we have a community, the way that we want to describe community, we have a strategy towards that. And then we can carry it out, but really, it needs to start. And it's in alignment with our strategic plan. And if you go back to that picture with the door, we had a internal staff conversation around that. And, it's always about, the powers that be or decision makers allowing communities to come into the space. But then that door goes both ways. And so, what does that look like for us to also be involved, out there? And so that's some of the, that we hear from other community organizations or just folks that are out there. They're saying, you always want us to come to your table, but, we'd like to invite you to our table, to really experience what's happening in those communities and be most underserved. And they may not even be formal community organizations. They might just be, folks that are really wanting to be heard, just like in China and all the outreach that's happening there. Yeah.
I just want to make I don't even know what to call it, I've been watching this conversation unroll at the state level for any of our OHA partners right now, but it's been clumsy and it's created a lot of, and not maliciously clumsy, it's just been clumsy. So we hear a lot of providers and community-based organizations and government. There's a lot of conversation that feels like you're in one landscape or another and never the twain shall meet. Well, I have 400 staff. Many of them are members of vulnerable and marginalized populations. Many of them cannot afford housing here. A couple are homeless. So I really want us in this community to figure out how to have these conversations together as members of our community. So when I read a stat like only certain percent are community members, what is that saying? Is that saying that because I'm part of an agency, I'm not a we have agency staff who use services. Many of my staff use many services. So I'm really asking that we not recreate what I think is not going to help people talk about this in some other settings. While not building the lily and imagining there are communities that don't. I'm not saying that. And you know that. We got to do both. And we are in community. Figure out how to talk about both stuff together. And then the last thought on that is all those agency partners want to come be in community, and often they can't be because they're so micro-regulated into oblivion, so slammed with work and administrative burden, this, that, and the other thing. They often can't find the time to show up. And now what's happening is these CBOs are being loaded with the same expectations instead of the reverse, which is relieve some of those expectations of let people do the job. And how do we act?
Well said.
Yeah.
So Miguel, I would also encourage you, if you see barriers that the board is creating to stand in the way of this work to go forward, please let us know that as well. So if there's something that you need us to engage on or something that you see as a barrier, please bring it back.
Thank you so much, Tammy. Really, our first job is to imagine that it's possible, because that's a very difficult challenge. But everything is there. If we begin to, it's a difficult job. I've been working on equity for years, and it's always rubbing against the surface, so it's difficult. But we need to do it.
Yes. Thank you. Wonderful. Okay, so we have Trisha next. Okay, I'm sorry, Rick Blackwell. Yes, you told me that. Look how quickly I forget things. So Rick Blackwell is going to be joining us.
He's on Zoom somewhere, right?
He's on Zoom. Rick, have you joined us?
Well, he was just in bed yesterday. So.
I see his head on there. On Zoom.
Oh, is he maybe on mute then or? I'll text him.
Hey, everyone, is it my time?
Yes.
Yes, we can hear you.
So sorry, I was on the call, I was on a phone call, so I saw my legislative update pop up. I thought I better pay attention. So just so everyone knows, I'm Rick Blackwell. I'm the Government Relations Director for Oregon for Pacific Source.
Rick, just one quick sec. Is it possible for us to turn it up a chance?
Oh, that might actually be my audio settings. Can everyone hear me?
Now.
Is it better?
Okay, let's try one more time.
Okay, can you hear me now?
Is it too loud? Rick is in the room.
Good.
Yeah, that's great.
Okay, thanks. I'll try to be as brief as I can. You've got my written materials for my June update. I think the way I described this session was dynamic. We were all in one hallway trying to have private conversations about bills. The Capitol is right now being renovated, and so I would prefer renovation than having bricks fall on me in an earthquake. So I appreciate it, but it also does kind of constrain both the amount of hearing rooms that are available for the legislature to take up bills, and just kind of the general flow of the building. So, as you know, the legislature was not active for a number of weeks, but deals were made as they usually are, and a number of bills passed at the end of session. What I've provided in the report in front of you is kind of some select bills that I thought would be of interest to the Health Council. There's obviously a lot more. We tracked about 384 bills total as Pacific Source. 84 of those made it out of both chambers into the governor's desk for signature. I did want to point out, well, while the governor has 30 days to sign a bill, it's 30 days without weekends. And so you were probably seeing the governor make decisions about legislation that was up until August. So that would be the 30 days excluding weekends. But one that we talked about, I think one that the Health Council, and I appreciate the Health Council considering signing on to a letter concerning House Bill 2446. But this is the bill that would have extended the current CCO contracts to no later than December 31st, 2026. We had a good hearing on the bill in the House Healthcare Committee, and they did adopt the measure. But in the time from when the committee adopted the measure, we had some dynamic leadership changes at the Oregon Health Authority. So we had a director resign, and we also had kind of a second look at the language as it was heading to the Senate. And normally you can get an amendment in the Senate if there's a language change that's generally agreed upon. In between the movement from the House to the Senate, we thought that the phrase "no later than" might actually not meet the intent of the legislature in extending the contracts for 2 years. And might actually start procurement sooner than anticipated. And so we had solely as Pacific Source testified in committee that we were hoping to strike that clause from 2446. At the time, the Senate had just really stopped meeting or stopped having a quorum to do business. And so the amendment did not move forward, just mostly on those grounds of we don't want to slow the process down. Our process did slow down anyway. In the meantime, we were able to get the provisions of the bill, House Bill 2446, into another bill, which is 1/3 of the nurse staffing package that the legislature worked on this year. So most of House Bill 3396 actually covers hospital discharge work group. So trying to figure out how to make sure to move people from hospital beds to lower levels of care as required or as appropriate to try to free up capacity in hospitals. But the bill had the right, what we call relating clause in policy nerddom, which is that the bill related to healthcare, and so any number of things could land in that vehicle. So the language from 33 or 2446 is actually there. When those two bills both passed, because 2446 eventually did, the legislature has to figure out, so we have a conflict now, what happens? The Constitution says which passes later is what controls. And so Legislative Council basically removed all the substantive provisions of the first bill, and 3396 then passed with the change. So the CCO contract will run until December 31st, 2026 now, instead of no later than. So that really gives the most amount of time, I think, for reprocurement. Now, Representative Nose, who was the chief proponent of 2446, basically has told folks that he is essentially running for office to stay, to keep on the procurement process. So I would anticipate that this will be a big issue or a big concern of his moving forward, at least for the next term of office that he would seek to hold. Any questions on that one before I move on to the rest of the update? Doesn't sound like it. Oh, go ahead, please.
I think we're good. Go right ahead.
Okay, very good. House Bill 2002, this is the bill on gender affirming care. I just wanted to flag this one for the Health Council because for the most part, the bill equally applies to both the insurance code. So this would be fully insured health insurance, but it also applies to the Oregon Health Plan. Now, that may not make much, it might not be much of a change for Pacific Source, as we were already fairly ahead in gender affirming care, but we'll be watching the implementation in 2002 just to make sure that the standards that HERC adopts, the Health Evidence Review Commission may adopt to implement 2002 are kind of in line with generally accepted standards of care. Let's see, the next one, Senate Bill 966. This was the big pre-session concept from OHA. So the governor introduced this bill for the agency before session started. This there was a lot of negotiation on 966, so it's very pared down from where it started. Interestingly, excuse me, this bill didn't actually start as 966, it was 967. 967 died because of a procedural matter, and then everything had to be put into this bill. Though what I would flag for the committee or for the council here is that the act will have some downstream and upstream metrics that will need to be looked at. So the upstream metrics that are in statute are health assessments for children in foster care, kindergarten preparedness, language access to culturally responsive healthcare, and screening for social needs and referrals. These four are in statute and will be reported, looks like, until 2027. One of the things that OHA wanted out of the bill was a work group to study the quality metrics program and to look at recommendations for program changes and subcommittee changes. So one of the things that was talked about in the 1115 waiver discussion was having two different committees to look at metrics. That didn't get into the bill this time, but the work group, my sense is that the work group is meant to report back to the legislature that a second committee will be needed to work through quality metrics. So we'll be watching the development of that report as well. Put some highlights in the report regarding House Bill 5525, which is the OHA budget. General fund was 5.6 billion to OHA, which was a 43% increase from the last budget, from the legislatively adopted budget. Total funds are 35 billion, so this would include federal match and other funds, fees, that sort of thing. A couple things to flag for the committee here, and of course it's in the writing in front of you. Healthier Oregon was fully funded to the 576 million, but then the Ways and Means Committee made a caseload adjustment of 113 million reduction from that. And that's just to note, levels of utilization of the Healthier Oregon program, which is, I think, fairly consistent with what happened with Cover All Kids as well. The 30% behavioral health increase that was required, well, I guess was in a budget note in the 2022 emergency board, extended through this biennium, funded to about $127 million. The Oregon Health Plan was fully funded, included a 3.4% rate of growth that was included in that. And then for redeterminations, there's 110 million set aside for redetermination process, the temporary Medicaid expansion. So Oregon has a temporary 1115 waiver to keep people on the Oregon Health Plan while redeterminations are happening, and the state can figure out when it will submit the blueprint, the basic health program blueprint under section 1331 of the ACA. Lori, that extension would be through the whole biennium, so 23-25. Let's see here. There's 138 million to implement the full 5-year waiver that we've talked about. So this would include trying to figure out the housing and climate components of the waiver that have been granted to Oregon. And then the state-based exchange was included in the legislatively adopted budget. So Oregon will be on a state-based marketplace, probably be by 25. So there's a 2-year process called stage gate that is for complex projects that need to be complex IT projects in the state level. Let's see. So that's the items I wanted to flag for you. There's a couple of behavioral health bills that Governor Kotek just signed. Looks like would have been Monday. One of them that we were watching was House Bill 2757, which is the 988, the funding for the 988 crisis line. So that included a 40-cent tax on wireless, prepaid and postpaid wireless to help fund the 988 trust fund. House Bill 2513 was Representative Nose's, reform bill on Measure 110, really focused on the oversight committee, how the agency, a more formal approach to how the agency looks at the Measure 110 accountability and oversight work that it's required to do. And then, let's see, what was the other one I wanted to point? There's a couple bills on, actually, there was quite a bit of legislation on expanding access to opioid overdose reversal medications and having standing orders to fill those prescriptions through the Oregon Health Authority, and to make sure that those doses were distributed to law enforcement, firefighters, EMS, and schools and other personnel to help with overdose prevention. Those have all passed and will be signed into law. And then I think that's probably about all I've got for you, unless there's any questions that I can answer for you. Anything that you were tracking or would like to know more about. I think I answered everyone's questions in the chat. Lori, yep, okay.
Senate 966, some of those metrics are also with the early learning hubs. Is there a connection there, or should there be?
Can I take the second part first? I believe there should be. I always like to see, having been in state government myself, it's better that divisions and departments coordinate. I can't tell you whether OHA reached out to the early learning division for that work. So that would be an interesting question.
Well, we might encourage that.
As would I, yes.
Awesome. Any other questions? Okay, thank you so much. Really appreciate your hard work.
Sure, thank you.
Okay, so keeping with the same theme, I'm going to go to Carmen next to talk about House Bill 3396.
Okay, thank you. So if you're looking at packet on page 84, This is really in alignment with what Richard Blackwell was discussing, that the extension of their CCO contracts will end December 31st, 2026. Our current JMA, which is our joint management agreement with Pacific Source, expires 2024, December 31, 2024. And so we are talking with our Pacific Source partners in terms of, how do we extend that same extension of our JMA contract to December 31st, 2026. So it's just an alignment. We're trying to explore right now what the vehicle looks like. Is it an amendment? Can we do it just with a letter of agreement? But I just wanted to raise this topic for awareness that we want to align our JMA contract with the same extension that the CCO is doing with OHA. So,
Okay, questions?
Questions? Okay, and we'll bring back more results on what that looks like next month. Okay, on that piece. And then the next piece, I don't know, Rick, if you want to speak to the behavioral health that we're speaking on shared savings.
Sure, so one of the concerns that I've raised with Carmen about our approach using the work groups is that currently behavioral health is really facing two big crises that's also impacted by housing. So one crisis is the state hospital system is in a bigger crisis than I've ever seen in my life. And my first memories are of the Oregon State Hospital grounds. So it's a disaster, and access is very limited. And then as community mental health director, who has to answer to Judge Crawford here about who's on the streets in Prineville, it gets really, really scary. There's public safety issues all about, and Deschutes has an even bigger problem because they have a higher transient population. So we have a huge crisis there, and the lack of investment in community-based resources in Oregon for decades has come to roost. So there's no place to put these folks. Second is fentanyl, which has been coming across the country, has hit Oregon and has hit Central Oregon really bad. We're just in the last year, really, 2 years max, but the last year, overdose deaths are skyrocketing, overdoses are skyrocketing. Interesting thing, when you revive somebody, we're getting people who've been revived, 15, 20 times, even sort of like a concussion to the brain. So I'm like, we're gonna have a bunch of people with boxer brains sitting out there if they survive. And the severity of the fentanyl makes heroin look like harm reduction, but you don't have to worry because you can't get heroin anymore. It's all disappeared and it's all fentanyl. And we've had to change our treatment practices rapidly in the last year, quite dramatically. Our doctors in our addiction medicine clinic and the detoxes have had to they're in monthly consultation with OHSU about the technicalities of withdrawal because the dependency is so high and the action before. So we really have a lot of crises. We've had more patient deaths in the last year due to fentanyl than we would have in 10 years before. And of course, they're all related to housing, interrelated and bidirectional. So I don't have set of proposals, you know, to march up, but I would really suggest that the process of the work groups is slow enough, is that what they're working on is 2 years out of date, and we have a couple of pressing crises. And so I would really recommend that some of that money be used for proposals to try to address those pressing crises.
The other piece, if you go to the shared savings, page 90, is that request for modification. So in our current GMA, our joint management agreement, any shared savings, 50% of it is actually invested into some type of behavioral health investment. As you can see, you know, Pat talked about the investment we made in volunteers in medicine and that behavioral component in changing behavior for diabetes. And I think that there is definitely a lot of current issues around behavioral health that what you just spoke to, and you know, I know Janice, you talked about the unhoused population, is how can we look at these dollars, because we do have dollars coming in, the considerations here is that our current shared savings from 2022 results to be received in 2023, and this is not out yet for any final dollars, but it will be close to 5 million for the 50% portion for behavioral health. And so what is that opportunity for us as a board to broaden the scope instead of just saying, we are going to invest this in behavioral health, but more about the emerging needs in our community. So we're also exploring this with our Pacific Source partners. Like, is this just a letter of agreement that to update this, or do we need a full amendment? But really, this is just, again, another awareness piece to broaden the scope, unless anybody opposes that. So really what we're trying to do is maybe take the social determinants of health look, like we heard that housing, it goes across each one, it touches behavioral health tremendously. And so is there a process of identifying projects that we would sort of lift from the existing way that we've invested in behavioral health? And then conversely, is there a process of vetting the eligibility of that spend with Pacific Source as well? So yeah, we would first have to broaden the scope if we wanted to go outside of behavioral health, since this language is here, and then we identify that what that process looks like.
Don't think we need to go outside of behavioral health. I think that would be a mistake.
Yeah, because they're tied together. So there's not a, I mean, if we're addressing the unhoused crisis, that's clearly going to touch on the behavioral health population.
Yeah, I think the issue is we really have two unprecedented crises going on in the state in behavioral health in these two areas. And frankly, the public discussion is 2 years out of date and is, you know, it's hit my agency so hard that the whole debate about Measure 110 is like, it's so dated at this point. It's like, oh yeah, well, that was really nice 5 years ago. Oh, and just a shout out to Pacific Source, I say this to our state representative here, is that my doctors are saying Pacific Source is the only CCO that isn't creating barriers to medications that are absolutely necessary to treating. And everyone else is like still based on, we have prescription drug addiction problems and creating lots of pre-auths and people are dying because of that. So I would really want to see the other CCOs about the Pacific Source standards.
So your request is to alter the contract, or it's just to spend it within the current budget?
I think it's that it's an optics. I'm hearing it more as like an optics issue, that it wouldn't necessarily be a straight behavioral health spend. I think it's more a variation of utilizing this in a different way. Unless, yeah, let's go ahead.
I just had a couple comments first.
Yeah.
So there's a new populated social benefit coming out, timeline currently specifically, the government has zeroed even further in, JRE, specifically looking at housing, individuals with SPMI. For a period of time, there's still so many more questions than answers, but that is on the horizon. Severe and persistent. And then second, kind of more late breaking, we had this ask from the governor a couple of weeks ago to show her, all CCOs, to show her what our investments have been in behavioral health and housing and other health equity, some other categories. That was kind of a scramble to get. We have, a great story to tell here, of course. And today was the day that the CEOs of the CCOs met to talk about what that data looked like. And so we have some kind of drafty marching orders from her that we'll have to talk internally first. But those are largely based around these sizable investments in behavioral health that we will need help from the Health Council to fulfill that promise to her just during this meeting.
So with the conversation that we're having, do you feel that there's an adjustment necessary for our JMA, or do you feel that there's a?
I don't think so. And I think it's even more helpful to have this region have this dedicated funding. Also, I'm not sure what the timeline will be for this one-time investment that we've asked CCOs to do. But it will certainly be it's a shared problem, of course. Shared solution.
Yeah, I heard that.
It might be PTSD, but I'm hearing this conversation in a different way than I've been hearing the other conversations that are what we want to do about collaboration and all that. What I'm hearing is we are facing a situation that's like COVID. And that demands both thoughtful and long-term strategies, and we can't waste a lot of time trying to figure out that. We need to be able to have the funding to come up with some innovative proposals, to be willing to risk, to do based on as much science as we have quickly in the way that we did with COVID. And I may be the only one that feels that, but I'm uncomfortable changing the funding formula in the middle of that in the same way I would have been uncomfortable at the first part of COVID. To change anything was just figure out what we need to do and how to get it.
Thank you.
So just to restate, because there's been a crisis in Knoxville volunteers for 5 years. We talked about it, but this group has never. It's always been hands-on the contract. This group can do nothing to fix that crisis. But when there's this crisis, then we can look at how to amend the contract.
This is the joint management of us versus.
So there's no contract change to change. But what do we ask? If the money's already allocated to people health, we want to use it for people health.
I think there's I don't know that we would have holistically thought that addressing the in-house crisis would have been a behavioral health need.
So it's a classification.
Yeah, I think it's a, and in that there likely would end up being some, fentanyl related, maybe strategic investments.
Decide on what the definition.
I think that's the conversation that we'll have. Yes.
Janice?
Janice, go ahead.
So this is my understanding of the behavioral health directives. They are to be directed for behavioral health. There are some fear, and that's why the contract conversation is a separate conversation. So I don't think the two are necessarily just for this, but I don't know that the J message. There is a lot in that space in addressing houselessness and opioid overdose crisis. That's behavioral health related, exactly in my foot James, and isn't a naturally covered service. So, for example, all of the outreach engagement and wraparound supports that we provide to people who are not enrolled, they're not an enrolled patient, because they're not ready to put their hand up and say, I want government health treatment or I want behavioral health treatment. So one of the proposals that I know is this talking that is even if you just took a chunk of those dollars and start them off to think about what we can never get, which is wraparound supports for all the housing that's being stood out. That does no good if you don't have case management and other things on site. And if you don't have a physician on site or PHPs on site, you can't build Medicaid care. So you're not breaking any rules.
Yeah.
It's still a behavioral health service that would go a long way towards supporting unhoused. So there's a lot you can do.
Okay.
Which is similar to what you were talking about with COVID. Right early on, we were able to provide all of these rapid support.
Yeah.
In a short space, which.
So I think that offers some clarity. I think the question is going to be, what mechanism are we going to use to identify what it is that we want to spend the dollars on in a strategic fashion? We're not going to resolve that today, but I would really encourage, there's getting ready to be an emergency roundtable that stood up around, very similar, lifted from the COVID crisis, around a house crisis, which then obviously is going to get into this is Deschutes focused, which is where most of the need is, but if we can fix it there, it's not gonna trickle everywhere else. So maybe that's an opportunity to have a conversation about what the identified needs are, and the gaps in the funding.
But there is no request for modification. There's
Not anymore.
one day something will show up with the proposal.
So what is the current process that we use for spending shared savings?
Well, it goes through the work groups and then the work groups. That doesn't.
What we did this past year is we took 3 of the work groups, we did that integrated process.
Okay.
And they came up with those 3 initiatives. We discussed that at the last board retreat. It was approved. And we're just excited about that collaboration and integration effort. The previous shared savings, it was decided that that spending was, it was for Deschutes County Older Adult Youth and Health, Veterans Association, Volunteers in Medicine, I forget the other one. And so basically, there is no normal process. I think every shared savings round, if there is money there, and we don't get it every year, there is an opportunity for the board to say, how do we manage this collectively? And right now, what I'm hearing is that there are some emerging needs in the community that is still aligned with that, so that a modification is not needed.
Is the current structure on how with the shared behavioral health that Carmen just mentioned, is that responsive enough to focus on fentanyl issue? Do we need to think about a structure focused on?
And it's something we could take up.
Yeah, I think we should take that offline
Right, yeah.
and make a proposal about what that looks
Sure.
like, but I think that's sort of the weakness of the process is it's good as long as everything's nice and stable and deliberate for a year, but
It's on the agenda item for our next meeting, our next board meeting next month. So we can work.
yeah,
on
I'm
that.
wondering if you and Janice and Holly and I can meet and sort of hammer out an idea of how.
Would it be possible for us to bring back to the board, like, how is it that someone else in the board determines that there's a crisis that leads us to divert funding? How can they introduce that?
Okay. That is a good question.
Right, so this isn't diverting funding from anything else, this is taking existing.
Changing whatever existing process was or whatever. Right.
There wasn't.
But it's just, it can be introduced in a week and then we can do something, or in a month, we can do something. I'm sure there are other folks that have introduced for 5 years, a growing crisis that never gets addressed. So how did they get to come and say, this is exactly the same thing, this type of attention, special attention?
Like emerging needs, you mean, like crisis, medical, and like.
How do those folks have to come and actually get their issue addressed in the same way?
And if I could add to that, when you guys come back next month to talk about what new process, what are the safeguards maybe that are existing in old processes, like making sure that our partners are included for regulatory compliance or whatever is a part of the process before it comes back to us. And reminding us from a governance perspective that our role is not to make decisions on grants and policies, but to set up a process that assures us that.
Right, that's what I think we need to do is come back to you guys with a process about, again, not new funding, but this existing behavioral health funding. Formal process, we had this twice and came up with different processes.
The language says as COHC determines, so. But I think it raises another good question that this money is only restricted for the purposes that we've restricted it. And so if we have other emerging crises, how are we addressing those versus utilizing what is a relatively slow process? Would we know that there are things that are more immediate? So I think that's an important conversation for us to have too. So in your packet, I want to offer or ask for some grace from our partners at Pacific Source. In your packet, you will find the CCO health related services presentation as well as the metrics piece. And so if we could have you review those, which I'm sure you did before you arrived here today. If you have questions, can we bring those back next month to take a peek at them? Trisha, is that okay? Okay.
Please
we're gonna
review and also March through performance metrics spreadsheet, so that when you have questions, here are the results, what are the strategies, what are the processes for improvement in those places, what are the validators and validators, those are all tabbed across at the bottom, so take a look at those and I'd be happy.
Okay, thank you. And I also want to just note that there is a community conversation that's going on right now, and Lynn, I'm sort of looking to you because we've been chatting back and forth about this. There's a potential shift within the structure of relationship between the Medicare partnership with St. Charles that is getting some conversation that I believe we have a responsibility as the Health Council to probably bring into the center of the table and guide it in a way that we seek clarity on what the what is and what the what is not, and have an opportunity to get clarity from our partner at St. Charles of what it is that this could be in terms of an impact to the region. And so I know that Linda and I have both heard some chatter, I would say, and I know Carmen has, and I just thought if this is maybe the elephant in the room for some folks, I want to poke at it a little bit and just say, are there questions that we feel that for those that, and this is where you can peel off if this is not important to anyone, but I think there's enough where we want to support our partner with the change, but if there's an impact, we also want to be cognizant of that and make sure that we're not losing out on an opportunity to support our mission, which is aligned with St. Charles, which is, you know, really working to create the a healthier Central Oregon together. So with that, are there questions that we want to bring forward that maybe we capture and then invite our partners at St. Charles to help us be informed?
I've been reflecting, knowing this conversation was coming with being in the meeting, I've been reflective and listening to what's been said, what's been happening today. And from the beginning of the meeting until this last conversation, it's been a demonstration of the Health Council's purpose. And so I got on the phone, no, I wasn't playing games. I was looking up the Central Oregon Health Council purpose, and I wrote it down, and I'd like to read it. Our purpose: we exist to build an equitable and integrated health ecosystem that improves the health of Central Oregonians through collaborative work and community partnerships, utilizing data-driven decisions to achieve quality improvements, lower costs, and empower providers. Our value to the region will exceed the cost of our efforts. When I put that statement in the context of what we've been talking about today, I think it's been a great demonstration of partnership, collaboration, whatever it costs to do it together, recognizing all of that has been contained in our conversation. The St. Charles potential decision that Tammy referred to, first of all, hits me personally.
Tell us what it is,
Is everyone aware?
No.
It's as I understand it, it's a potential notice or an actual notice not to renew the contract. It's the Medicare Advantage. I'm not a Pacific Source client. I have Medicare Advantage through another company. As if I look at, okay, they do that with Pacific Source, and
a huge number of people in Central Oregon, not Medicaid recipients, but are charged for the regional health improvement. It is our goal to have a stake in this. I, my 93-year-old mother, all my friends, anybody over 65 could potentially be impacted.
I'm sorry, it sounded like you said canceling Medicare Advantage plan, like solely for like one insurance company or all Medicare.
Today, as I understand it, and you might have an expert in the room, today it's Pacific Source. The question is it everybody? Who offers
There's no
Medicare?
hospital in America that's cancel all of it. It's like, how would anyone? There's no version of the world. You're talking about people who base themselves at 65 into Part D and other plans, and then at 75 they kick back. They'd have to spend hundreds of dollars a month. There's no way any nonprofit hospital can do that.
These are questions for this one, and so Jeremy, do you have?
Yeah.
Well,
Jeremy's here for the second.
I can give a quick update. So, and there has been some chatter in the community. We've been trying to be sensitive about when and how to talk to folks. So just kind of bring everybody up to speed. So, we received the notification of intent from St. Charles to terminate our Medicare Advantage. Be clear, it has not been terminated. They for some technical reasons I won't get into, but through that process of some back and forth, it became very clear that they were intending to terminate the agreement. Just for context, we have 50,000 Medicare Advantage members in Central Oregon, including 2,500 dual eligible members who are Medicare eligible. We've been trying to get clarity on that because it was not clear to us whether this was a negotiation or change requests for change contracts. We're still working really hard to try to get St. Charles to the table with us to get some clarity around that. Our understanding is it could be part of a larger business strategy move away from Medicare Advantage more holistically. And I don't want to speak for St. Charles around why they want to do that. They told us broadly just administrative concerns and financial concerns. But we're still working very hard, still very optimistic. We've got a long partnership with them, asking them to get to the table with us to try to get clarity on what the issues are and try to resolve those. And clarify whether this is a Pacific Source only issue or under business strategy. But that's kind of where we're at. We've sent several lower, we're really focused on impact on members who open up coming up in a month and a half. We don't have a terminating contracts, so we're just worried about the sort of confusion in the community, right? At the time, I think if this is a broader, decision around not offering Medicare Advantage, that'd be a conversation. That's kind of what that.
Sorry, on first reaction, this gotta not be true. That has to be one. Then what's wrong? No place to be that simple. There's no version. I mean, I know what you're going through, but no, but then I think we need to come back and have a conversation. Because really, and I do agree that it does belong to health council because, for 5 years now, we've allowed them to operate as a for-profit hospital under a nonprofit tax. And every year when contract negotiations comes up, everybody bends because, you have this conversation about you have to have a hospital. And, isn't it worth doing bankrupt to have a hospital? And I think people are probably going to get to the point where, no, it's not worth going into bankruptcy to get healthcare. And I think we've let the community down for 5 years by not having that conversation. And I think everybody here is culpable for not having that conversation. For every year that's going, more money. The only way you can survive is more money. So if it's a financial decision, I think that's really core. I do agree. You have to hear from them because maybe there's something we don't know that would make more sense because that makes no sense.
Yeah, and I just want to be really clear. As an organization, we have always sort of held by the policy of we don't want to drag anybody else into our contract. Nor do we want to hear. I will say, I think it has been concerning to us. Maybe this is a broader decision, not related to us, but more of a policy. It's put us in a bit of a weird spot of, okay, there's potentially huge disruption coming.
Yeah, how do we navigate? It's important. And last month, the board retreat came up. We haven't been having conversations.
Yeah.
And so next month, of course, naturally what happens. And if you use our purpose statement, Is this decision, what is our role in building relationship and attendance? What is our role in making sure that patients are at the center while we're here? What is our role to create an environment, or the opposite of creating, destroy possibilities for collaboration and data-driven decision? What is and what does it mean our value to the region will exceed the cost of our efforts if we find one of our partners in a position where they may or may not be considering that? What is our role as a council to move forward? And so for me, the question at the end of the day, setting aside my personal stuff, it's just I think the council has a stake in this. I think it's time for us to really start to define what's our role.
Just said one thing, because lowering the total cost of care is part of the issue too. But and that means all nonprofit organizations not making for-profit decisions. But just to be clear, I'm sorry, this is so mind-blowing. It's just,
yes,
if I were a Medicare Advantage patient at 65, I can get Part D and a supplemental at a good price. If I chose a Medicare Advantage plan for a decade and I got thrown off of it by a hospital system that didn't want to take it, my premiums, they're going to be 10 times higher than they were at 65. You're talking about people on a fixed income having hundreds of dollars more in premiums every month.
I should mention that.
So that's 20,000 or more people.
I did reach out to St. Charles, and I did reach out to Dr. Gordon, and he did respond back. So you all know me well. I have a playbook. It has one page, and it's no surprises. And I knew that this was going to be coming. I think it's something that if we can, they did not dispute that this is a change that will be coming. They did not. But I also knew that Emily, our liaison to St. Charles, our board member, was not going to be here today either. And so I just so that you know, on your behalf, I did reach out to Emily and Steve. So I think if we can find a way that we can get the questions that have come up, and we lead with what is our role? Our role is the patient in the center of all of this. What might we need to know in order to be fully informed as a health council if this change were to occur? And I did not receive anything that would lead me to believe that this is not changed or something. And we may not be able to capture all those questions right now, but I think we've come up with a pretty good list, and we may want to, in that light of being able to, I see facial expression there. We may want to be able to ask St. Charles to provide some insights into what we anticipate to be some of the impacts, and maybe clearly there should be some benefit to a significant change, and maybe they can offer some clarity of what those benefits might be to making this change.
Outside the financial viability of the nonprofit organization.
Well, I would leave it to them to determine what they see as the benefit to the community that this would be able to break forward.
Not that stuff that makes sense.
So, but it's an opportunity for them to be able to share among their colleagues in the community of what it is that they see as the benefit to the community. So, maybe go ahead, Brad.
Just to clarify, so is the notion that they would just be switching providers, insurance companies, or they just wouldn't like?
Well, I think that's a great question too, and I don't want to presuppose decisions. But again, I think we want to.
I don't know what it means either, fair enough, but in theory, if you were canceling the line of Medicare Advantage products, you'd be leaving patients to fall back to straight Medicare. And Medicare has a whole list of things that has a cost share. That's why you buy Medicare. And to be fair, those Medicare Advantage products in this community, they're the best they are anywhere. Like, not just specific to us, but a lot of the Medicare Advantage plans, they put up meal support, transportation for patients. They do things straight Medicare can't do. But if you fell back to a Medicare plan, you'd have a cost share. So there's a cost share. So those patients who have not had that traditionally and are on a fixed income now, they're going to have to pay a portion of their care, or they can go buy a supplement. But supplementals are real cheap right when you go on Medicare. You don't get on them right when you go on Medicare. You go on them 10 years later. The supplementals are really expensive. So one way or the other, the 75, 80-year-old who's on fixed income now, I mean, we have trouble getting people rent for a $10 office trip. Give them a couple $100 a month Part D supplemental payment. But so theoretically, that's what it means, but you're right, we don't know, so we should hear them out.
I think it would be incumbent upon us to gather the information as a health council to be able to know what it is that the change might be. So there had been enough chatter before this meeting, at literally the last day, so my apologies for not getting this out earlier. So we're gonna set this one to the center of the table and get some questions answered, and so that we can be informed as we are thinking about our voice in the region. So thank you, Linda, for moving that forward too, and for reconciling us back to our mission.